session 1, video award session. Dr. Shishir Varghese, Dr. Hema, Dr. Neena, Dr. Thanya, and Dr. Arun Lal. Only Arun Lal is present. Okay, so you can come to front. Huh? Okay.
Scoring paper is given. No. Putty. Scoring paper. Marks. Marks is yes. Right. Inside it is. Yeah. 3 will be there.
So we'll start the session. We were waiting for our third judge, but sir is having another presentation. So we'll start the session. Dr. Shishir Varghese.
No, audio is there. Yeah. Thank you, KSOS, for giving me this opportunity. I'll start my video.
Visualizing the obscure, chromophore-assisted retinal break detection. In today's era, vitreoretinal surgery has seen improvements in technology, use of small-gauge instrumentation, and improved visualization systems. Despite these improvements and as well as the use of flawless surgical skill and techniques, about 10% of cases still require repeat pars plana vitrectomy for recurrent retinal detachments. Proliferative vitreoretinopathy or PVR is the most common cause of recurrent retinal detachments. The other cause for recurrent retinal detachments are retinal breaks, especially missed retinal breaks. According to a study, missed retinal breaks are the reason for 64% of failed RD cases. Missed breaks in recurrent retinal detachments can be challenging to detect due to prior laser scars, pigmentary changes or lack of contrast from the choroid. We describe a technique of occult retinal break detection, where BBG dye is injected into the subretinal space with a 41-gauge cannula and the plume of the dye emanates from the occult break. We demonstrate the use of this technique in the next few videos. A 62-year-old male presented with decreased vision in the right eye. He underwent pars plana vitrectomy for rhegmatogenous retinal detachment 3 months back. The right eye vision was hand movements and anterior segment examination revealed pseudophakia. There was no view to the fundus. B-scan revealed dispersed vitreous cavity hemorrhage and retinal detachment. He was planned for a repeat vitrectomy. Intraoperatively, a retinal break could not be localized and hence subretinal injection of BBG dye was thought of. BBG dye was loaded in the subretinal injector and the injection pressure was lowered. A 41 gauge needle was used to inject the dye in the subretinal space. PFCL was injected to displace the dye to the retinal periphery and the plume of the dye was noticed emanating from the now visible break. We show this again in slow motion. A relaxing retinectomy was done followed by endolaser, fluid air exchange and silicone oil injection. Three months post-operatively the retina was attached under silicone oil. We use this same technique in another patient where we inject BBG dye in the subretinal space to visualize the occult break. We should make sure that there is no air in the injector or there will be an inadvertent injection of air bubbles in the subretinal space as you see here. The rest of the surgical steps were similar to the first case. 3 months post-operatively the retina was attached under silicone oil. In another case of recurrent retinal detachment, after peeling the PVR membrane we injected subretinal BBG to search for occult break and found none. We drained the subretinal fluid after making a draining retinotomy. We used BBG dye which is the least toxic to the retina as compared to trypan blue or indocyanine green. One study utilized the transscleral route of trypan blue dye injection which can have potential complications. Only 2 other studies exist in literature utilizing trypan blue dye for subretinal injection to detect breaks in primary retinal detachments. To conclude, subretinal BBG dye injection is useful for occult break detection as it provides a color contrast. It helps in avoiding a posterior draining retinotomy and is useful in recurrent detachments where it is difficult to localize a break. We used BBG which is least toxic and report its use for this purpose in Indian eyes.
That's a nice video.
Can I
Thank
just
you.
ask one question?
Yeah, sure.
Have you compared you using dye without using dye?
No, actually, without using dye, I've done previously. I've not put it up in the video, but we won't know where the break is because you sometimes when you
Yeah.
put the PFCL, the subretinal fluid will just come out, but we won't know exactly where it is coming out
So
from.
no,
So
why
this,
I'm asking that question is because you will know that without using the dye, what would be the percentage of recurrent. In future, probably you could just compare.
yeah, so these are all described for recurrent detachments, what I have described, not in the, as a primary surgery. In the primary surgery, I don't inject in the subretinal space, only for recurrent detachments where I don't know where the break is because of multiple laser scars, lack of choroid, contrast from the choroid and things like that. So only for those I have used the subretinal, not for as a primary retinal
Primary
detachment.
retinal detachment. Okay, thank you.
So
Thank you.
you are inducing an RD by injecting the dye
No,
subretinally.
no, these two, all three cases already have an RD, but I don't know why the RD is
But
there.
you are creating RD by injecting subretinally, no?
No, no, RD is already there. I'm just
Okay.
injecting the dye already under the retinal,
Under the detached retina
under
only.
the detached retina, just to
Okay.
see why it has detached, where the break is. Usually PVR causes the detachment, but in the first two cases there was no PVR. So I just want to know why it has detached, where the break has happened. So for that I have injected the dye. In the third case, there was no break. It was only PVR which is causing the retinal detachment. So I had to check that, really confirm whether there was a break or not. So I injected the dye in the third case also.
Any
So
chance of toxicity
yeah, so
regarding?
actually, ERG studies have not been done, but thing is, in a recurrent little detachment, I doubt whether ERG will really show whether it's a toxicity because of the dye or whether it's because of the little detachment that there is no photoreceptor layer. But among all the dyes available, BBG is the least toxic. It is mildly toxic to the RP, but the least among all the four which is available.
Okay, thank you.
Yeah, thank you.
So the next presenter is Dr. Hema. She'll be showing a video on a skillful surgeon for an this is another artificial alien tackling retained intraocular foreign body.
This presentation showcases different methods of intraocular foreign body removal, their pros and cons, thus aiming at enlightening the audience for an effortless removal of IOFP. Our first case is a case of 36-year-old car mechanic with a vision of 612. CT scan and B scan revealed an intraocular foreign body. Anterior segment examination showed a corneal tear, sphincter injury, and a traumatic cataract. The lens aspiration was done, which revealed a pre-existing large posterior capsular rent. An intraocular foreign body was seen in infratemporal quadrant with adjacent sclerosed retinal vessels. Vitreous was generally cleared all around the intraocular foreign body, and the foreign body was allowed to gently fall on the retina all on its own. A 23 gauge magnet was inserted. The intraocular foreign body was safely lifted from the surface of the retina. A magnet helps us to hold and safely lift the foreign body without a fall than using a forceps. You can see the intraocular foreign body is brought behind the pre-existing PC rent without a fall. The IOFP was removed using an iris claw holding forceps through the same pre-existing PC rent. As this was a clean case without much sign of infection, we implanted an intraocular lens. Through this case, we highlight that the magnet gives us a firm grip of intraocular foreign body without causing a fall than using a forceps. The second point is that in cases like this where there is a pre-existing large PC rent, the same rent can be used as a route for the removal of intraocular foreign body than using a pars plana route. Our second case is a case of 32-year-old male patient with a history of penetrating scleral wound repaired 1 month back. Intraocular foreign body was missed during the primary surgery. The patient presented with vitritis and repeat B scan revealed an IOFB. He had a vision of 612. Vitrectomy revealed an intraocular foreign body. As this patient had a clear lens with a small intraocular foreign body, our plan was to go through pars plana route so that the crystalline lens is not disturbed. We did it bimanually using a magnet and a forceps with the aid of a chandelier illumination. A 19 gauge magnet used in this case serves in two ways: lifting the eye of B without a fall and aligning the eye of B on the forceps in the correct axis for its easy removal. This case highlights the importance of CT imaging in suspicious case of metallic foreign body even if B scan is normal. The bimanual method helps us in removal of eye of B through pars plana route without damaging the crystalline lens. Magnet is an excellent tool serving multiple functions in an intraocular foreign body removal. This is a case of a 64-year-old male patient with traumatic cataract and ruptured capsule following an injury at the construction site. The CT scan revealed a large intraocular foreign body. The traumatic cataract was aspirated and vitreous hemorrhage was cleared. But there was no signs of intraocular foreign body internally. We explored externally at the site of primary scleral tear repair. A thorough exploration revealed no IOFB externally also. Now we have a situation with an IOFB in the CT scan but no signs internally or externally. The pars plana region was cleared. We could see a metallic shine at the region of pars plana. We nudged the area and an intraocular foreign body was noticed. It was grasped with a 3-pronged forceps and was externalized slowly in a controlled manner. At last, here comes a large intraocular foreign body. The lesson learned in this case is how the objects in the CT scan is projected more posteriorly than it actually is. We thought the IOFB was at the level of the retina and searched internally, but it was actually at the level of suprachoroidal space. Thus, it is projected more posteriorly on the retina in the CT scan. A pre-planning of IOFB removal with the aid of CT scan is highlighted in this case. The retinal detachment in this case was managed with a silicone oil infusion. All cases are not necessarily superficial or over the retina so that we can easily grasp it. They can be incarnated deep subretinally even to the suprachoroidal space. Our next case is such a case. An anteriorly located such an IOFB can be removed externally, but posterior suprachoroidal IOFB has its own challenges. The most important point is to remember is a massive suprachoroidal bleed. Here the surgeon is attaining a proper hemostasis to aid the removal of IOFB using a laser and diathermy. Also, IOFB should be removed in a controlled manner and the infusion pressure should be kept high to avoid massive choroidal bleed. Thus, these 3 steps, diathermy, laser and high infusion pressure, help us to avoid massive choroidal bleed in this case. Here, the surgeon is trying to remove the IOFB with a forceps. We can see that the IOFB is falling on the retina multiple times. If he had used a bimanual method, as we have discussed earlier, this could have been prevented. The take-home message in this case is the importance of a hemostasis in deep intraocular foreign body, and once again highlighting the importance of bimanual method.
So last case was not yours.
Yes, ma'am.
Then why did you use that bimanual technique?
Actually, we thought it was actually a big, moderately big IOFP which can be grasped with the forceps. So we thought it can be removed. But after grasping it only, we found it was falling down. And in next 2 steps, it came out. But initially, also we wanted to highlight this can be a mistake and we should be precautious. Even for any size of IOFB, it is better to use a bimanual.
Okay, and also you haven't used that magnet also.
Yes,
last
ma'am.
case.
Bimanual with magnet and forceps.
In your third case where you found a large foreign body, did you consult the radiologist? I mean, I think you wouldn't have got a doubt, I think. You would have thought it is in the...
Yes, ma'am. Actually, we thought it is in the subretinal space, and that's why we went internally and externally. And internally also, before nudging the pars plan and clearing the base shaving, we couldn't find any suspicious lesion. I mean, points towards IOFB. Then when we were pressing and after clearing the base shaving only, we found that suspicious metallic shine. When we couldn't find internally, we thought it will be an externally.
Externally, so you started exploring outside.
Outside also.
Why did you do a B scan for that patient?
Yeah. The next question is, did you do a B scan early before sending the patient?
B scan.
Or do you do routinely B scan?
We do routinely B scan, ma'am, but this patient already had come with CT scan from outside, referred with the CT scan. So we directly took. But for all cases, we usually do B scan. And in suspicious cases, even if there is any sign of any corneal tear, lens cataract or iris tear, even if the B scan is normal, we always do a CT scan, especially for medico-legal causes.
So the point is, even if you have a CT, better to do a B scan also. B scan is readily available in department, no?
But this minute difference might be missed in B scan also. The plane is better in CT scan than in B scan. We will understand which is the plane.
It is just given a linear...
just a small shadow for such a big foreign body.
But I think it was not like horizontally placed. It was placed in like radial, not in a oblique manner. That's why in multiple cuts we are getting the shadows.
Okay, good.
Thank you.
Thank you, ma'am.
Start. Dr. Neena.
Posterior capsular surprises in pediatric cataract surgery. Pediatric cataract is challenging because of its high risk of complications, and managing the posterior capsule is of utmost importance in maintaining a clear visual axis. Here we share a series of cases which pose challenges in the way of posterior capsular management. Case 1 is that of a 2-year-old male child who came to us with intermittent inward squinting since birth. Anterior segment showed this deep AC with a central globular appearance of the lens resembling a subluxation. Ultrasound B scan showed a conical protrusion of the lens capsule, and we did an examination under anesthesia which confirmed the presence of a posterior lenticonus, and we decided to proceed with cataract surgery. After a careful anterior capsulorhexis, we proceeded with irrigation aspiration of the lens matter bimanually, keeping the parameters low, and post lens aspiration we found a posterior capsular opacity, and on trying to do the posterior capsular rhexis, I found that there was no posterior capsule there, and it was just an area of lens epithelial cells bridging the defect. So a vitreorhexis was fashioned with the vitreous cutter, and an anterior vitrectomy was done to make the posterior capsular opening and to clear the visual axis. And finally, after instilling triamcinolone acetonide to ensure that there is no vitreous in the anterior chamber and in the sections, we proceeded with an intraocular lens implantation. You can see that the anterior segment being cleared of the triamcinolone, and the 3-piece intraocular lens is being implanted. It is dialed into the sulcus, and the optics are captured under the anterior capsular rhexis. And finally, after removing the viscoelastic, the eye was closed. So posterior lenticonus is often associated with cataract and posterior capsular deficiency. And another important sign which you may find is that of the fishtail sign, which you can appreciate on moving the eye, showing the prolapsed cortex into the vitreous cavity. Case 2 is that of a child who presented with intermittent exotropia, central opacity in the form of an egg in the eye appearance, and ultrasound B scan again showing a conical protrusion of the posterior lens capsule. So suspecting a congenital posterior capsular deficiency, we proceeded with an examination and anesthesia and cataract surgery. Here you can see the cataract was almost near total, and after staining the anterior lens capsule, we are proceeding with the capsulorhexis, again trying to make a relatively smaller rhexis as compared to the usual standards, because we are expecting a posterior capsular defect in this case. So after anterior capsular rhexis, again a bimanual irrigation aspiration is done to remove the lens matter. And here, soon after the central chunk of the lens matter was removed, you can see that there is a large elliptical shaped posterior capsular defect which is seen in the center, which was corresponding to the egg in the eye appearance on the torchlight examination. So the large elliptical posterior capsular defect is now visible, and using cutter and irrigation aspiration, we switch between cutter and irrigation aspiration and clear the vitreous as well as the cortex from the pupillary area and from the bag. And after doing a careful posterior capsulotomy as well as anterior vitrectomy, again a 3-piece intraocular lens is injected, dialed into the sulcus, and the optics are again captured in the anterior capsulorhexis margin, ensuring a good lens centration. So finally the viscoelastic is removed, and the eye is formed with saline and air bubble, and ports are secured. So here you can see the eye being sutured with 10-0 polyglactin sutures. So the child did very well, and the pre-existing posterior capsular deficiency signs would be a conical protrusion of the posterior capsule with prolapsed lens matter into the anterior vitreous. And here you can see the child maintaining good alignment and a clear visual axis. The third case is that of a 1-year-old child, again with intermittent exotropia of the left eye, central cataract. Fundus was suspicious of a stalk running from the optic nerve to the posterior lens capsule, but ultrasound B scan did not show any stalk. Again, we took the child for examination and anesthesia and proceeded with cataract surgery, again with reduced parameters of irrigation aspiration, and a careful anterior capsulorhexis was fashioned. You can see anterior capsule stained with trypan blue, and a careful capsulorhexis is fashioned. So a bimanual irrigation aspiration is planned, and the aspiration and irrigation parameters are kept very low so that in the inadvertent event of a posterior capsular deficiency or a defect, there is no sudden deepening or shallowing of the anterior chamber. And here a posterior capsulorhexis is done, and you can see the stalk running from the optic nerve to the posterior capsular plaque, and we are cauterizing the stalk with an endocautery so that it should not bleed and produce a vitreous hemorrhage, and we need to call a vitreoretinal surgeon for help. So the cauterization is marked by the appearance of the air bubble. You can see here and the plaque is eaten away with the cutter. So the posterior capsulotomy and anterior vitrectomy is completed, and triamcinolone acetonide is injected to ensure that there is no vitreous in the anterior chamber. The bag is good, but because the posterior capsular defect is large, again we are instilling a 3-piece intraocular lens, this time dialing it into the sulcus and again capturing the optic in the anterior capsular rhexis margin so that the IOL is centered well. So here again the optic capture is done, you can see. Anterior chamber is formed with the line and the bubble, and ports are closed. So these are intraoperative findings of the presence of the fibrovascular stalk running from the optic nerve head to the posterior lens capsule, and postoperatively child was able to maintain a good visual axis, a clear visual axis and good alignment. Thank you very much for your patient hearing.
Anyway, we need a primary posterior capsular rhexis and anterior vitrectomy, no? Whether there is deficiency or not.
Yes.
Then any other increased risk you notice for this?
Yeah, so if you have noted, I didn't do a hydrodissection in any of these cases. So that is the point I wanted to stress, because most of the time, if you just do a hydro, the whole lens nucleus, which is anyway soft, comes out, and your surgery lens aspiration is over in a jiffy. But in these cases, you have to be careful. Just because the lens matter is soft does not mean that it cannot have a posterior capsular deficiency or a pathology. So ideally, you have to have a good preoperative assessment. Most of these children will not cooperate for a slit lamp examination, and you should have a high index of suspicion. Do an examination under anesthesia and check your B-scan parameters very well, and so that you avoid an inadvertent lens matter drop. Even if it is small, sometimes it needs to be removed if it is significantly, large.
Can you do visco dissection instead of hydro?
In these patients, you can do, because I didn't do any hydro in any of these patients. What I do is that when I go with the bimanual irrigation aspiration, I try to tease out the lens matter, and luckily because the lens matter is soft, it will come out as a whole, and you can eat it with the bimanual irrigation aspiration.
Was there any situation in all these 3 cases you have placed the lens in the sulcus? Was there any situation in any other case where you are placed in the bag?
Yes, if the posterior capsular rhexis is, you can make it into an ideal one as you are planning it. Normally we place it in the bag. So here in these cases, in the second case, there was a very large posterior capsular deficiency which was pre-existing. So I had to convert it into, a larger one. So putting it in the bag was totally out of question. In the first and second cases also, we could have tried, but since I had to do a vitreorhexis, and vitreorhexis is definitely not as structurally and functionally strong as a manual rhexis. So I didn't want to take a chance and and you're putting a 3-piece IOL, dialing it into the bag can sometimes, injure your further posterior capsular rhexis. So a safer option definitely is to putting a 3-piece lens and capturing it in the anterior rhexis, because it will ensure good stability. But regularly we plan it in the bag.
How about, do you do peripheral iridectomy?
Iridectomy. I don't do iridectomy in routine cases because I'm putting it in the back. Even if I'm putting it in the sulcus, I have a good posterior capsular opening. It's very unlikely to cause a postoperative glaucoma.
Thank you.
Next, Dr. Divya.
Various pediatric retinal diseases can cause tractional, exudative, rhegmatogenous or combined retinal detachment. Vitreoretinal surgery in pediatric eyes is challenging due to its anatomic variations, different etiologies, delayed presentations. A good pre-op assessment helps to decide on the need for lensectomy or any anterior retinal drag, which is very important in these cases so as to avoid any iatrogenic anterior retinal breaks while placing the cannulas. This is a case of a stage 4A retinopathy of prematurity, wherein you can see that the retina is dragged temporally and the surgeon plans to place the sclerotomies sparing the temporal quadrant, and the surgeon is sitting on the right side of the baby to operate the left eye. In this case of lens sparing vitrectomy, the trocar is vertically entered to place the cannula so as to prevent injury to the lens, and the entry is through the pars plicata as the pars plana is underdeveloped in these preterm babies. This is another case of stage 4B retinopathy of prematurity where the retina is dragged temporally and anteriorly, requiring lensectomy. So the sclerotomies are placed sparing the temporal quadrant, and the entry is horizontally into the lens so as to avoid any iatrogenic retinal breaks. After lensectomy using cutter, the membranes are dissected bimanually using scissors, forceps and cutter under direct microscope illumination. The aim of the surgery is to remove the membrane and release the vitreous traction. This case of a boy with stage 3B Coats disease with total retinal detachment. The aim is to drain the exudative fluid externally and to treat the telangiectatic areas. AC maintainer was used in the same quadrant of drainage in this case so as to avoid lenticular injury and to ensure near complete drainage of subretinal fluid. Belt buckle was put to support the peripheral avascular retina as vitreous dissection would be difficult in the periphery. It is important to identify the posterior hyaloid plane as these cases may have associated vitreoskisis. A bimanual membrane dissection is usually required as the membranes are usually adherent to the thin underlying retina, which is avascular in the periphery. The anterior vitreous was carefully cut using the cutter. Anatomy was applied to the vascular stalk before cutting under direct microscope visualization. And it is better to avoid pulling as it may cause peripheral traction and retinal breaks. The posterior stalk is trimmed from above the disc after endocautery so as to reduce the ooze. Vitrectomy was completed using triamcinolone acetonide and ILM peeling was tried after staining with PPG. Peripheral retinal examination was done which showed areas of nasal abnormal vitreous addition with small break, which was cryoed. This is a young boy who presented with decrease in vision in the better eye. The examination showed a superior retinal detachment along with a retinoschisis. Triamcinolone acetonide vitrectomy is indicated in these cases as the vitreous is usually very adherent over the inner chassis wall. These cases are challenging because of the multiple retinal breaks which are usually sieve-like, which is seen in the outer retina. Drainage retinotomy, if required, should be done corresponding to the outer retinal break area so as to ensure complete drainage of the subretinal fluid, which is important to do barrage to all the outer retinal breaks. A laser uptake burns helps to identify if the retina is attached. Do remember these surgical pearls while operating on pediatric eyes. Thank you.
How was the post-op visual outcome for the first two cases? First two cases.
Wait.
You don't remember?
That was start of case.
It's okay.
I think you showed three cases.
The post-op, actually we had rehabilitated the baby with glasses, and the long-term follow-up I don't have of those babies, but anatomically they were better doing. The useful vision was there, that ROP cases which I operated.
No, I would ask the surgical success rate in your hands. What would it be? Just
in ROP?
Yeah,
or
in ROP.
General?
ROP.
For stage 5, I would say maybe 40%, and in stage 4A, it would be 80 to 90%.
Okay. The other thing is what I think is the visual rehabilitation in these children.
Yes. So
if you have knocked off the lens, probably you'll have to give the phakic glasses. So
yeah, we prescribe it as the cornea clears. That is like approximately 2 to 3 weeks, or at least by 1 month. As the baby becomes less symptomatic, can open the eyes, then we do retinoscopy and prescribe phakic glasses. And follow up with the pediatric ophthalmologist also for further follow-ups.
Yeah. Resurgery rates, if you have any figures. Resurgery, second surgery?
Second surgery, yeah, maybe in 10-15% of the cases. Especially when the baby is present with vitreous hemorrhage, and sometimes you see that in the first surgery these membranes may not be completely removed, and you see most of the retina gets flattened, and if some residual traction is there, we feel that okay, that is going to change the outcome further, then we take. So it will be like around 10-15%.
Thank you.
Next, Dr. Arun Lal.
This video is intended to discuss about various abnormal head postures due to ocular causes. Nearly 1.1% of the patients presenting to the ophthalmology clinic have abnormal head postures. Abnormal head postures can be caused by ocular and non-ocular diseases. Commonest ocular causes are nystagmus, superior oblique palsy, cranial nerve palsies, lens retraction syndrome, and astigmatism. Abnormal head postures are adopted to improve visual acuity or to avoid diplopia or to obtain binocular single vision. Abnormal head postures can be a face turned to right or face turned to left, or chin elevation or chin depression, or a head tilt to right or left, or a combination of this. Abnormal head postures may be an essential clinical sign for an underlying disease. A comprehensive eye examination is a must to rule out orthopedic and neurological causes. Long-standing abnormal head postures may lead to facial asymmetry and secondary musculoskeletal changes. Hence, when strabismus is present with abnormal head postures, it's an indication for surgery in majority of the cases. In this video, this boy had significant face turned to left and the eyes are in dextroversion. This is because the child was having nystagmus in all gazes, which is getting dampened while adopting right gaze, probably the null point. In order to keep the eyes in dextroversion, the child adopts face turned to left. This is another case of face turn. Here the face is turned towards right and the eyes are in levoversion. This is a case of type 1 Duane's retraction syndrome, right eye with abduction limitation. So the patient will have diplopia or confusion while looking to right. So he prefers left gaze. To maintain this gaze, he adopts face turn to right. This is another case of face turn. Here face is turned towards right. This is because this patient had right LR palsy with -4 to -5 limitation of abduction in right eye. All other movements are full. In order to avoid diplopia, patient prefers the left gaze with face turned to right. On levoversion, the patient won't have diplopia. This video is showing significant chin elevation in this 8-year-old boy. We can observe there is marked exodeviation in up gaze, but exotropia is decreasing in the primary position and almost nil in down gaze. This is a case of V exotropia. Here, in order to avoid up gaze and diplopia, patient acquires a chin elevated posture. Similar to the previous case, this boy also had a chin elevation. See from the video, this patient had a ptosis in the left eye which is partially covering the pupil. Extraocular movements were full. While keeping the chin in the elevated posture, child was able to see binocularly. This is a case of congenital ptosis in left eye with chin elevation. This is the third case of chin elevation. Here one can see limitation of elevation in adduction in the right eye. This is because the child is suffering from right brown syndrome. So the patient avoids up gaze by keeping the chin in the elevated position. This is the images of two kids with right superior oblique palsy. We can observe head tilt to left side. Long-standing superior oblique palsy can lead to musculoskeletal changes and facial asymmetry as evident from the first and second images respectively. Isolated superior oblique palsy present with hypertropia of the same side and head tilt to the opposite side. This patient has got left superior oblique palsy. This video is showing hypertropia of left eye and alternate cover test showing L by R. There is significant superior oblique underaction in the left eye. On head tilt to right, hypertropia is decreasing, and on head tilt to left, hypertropia is increasing. Hence, the patient adopts right head tilt. In isolated superior oblique palsy, hypertropia will get better on opposite head tilt and get worse on opposite gaze. Thank you for watching.
Have you seen torticollis?
I have seen torticollis, but it is not here.
Yeah.
It is
you'll have to roll
case,
out.
yes, of
roll out
case only I included in this video, madam.
Not included.
Not included.
Okay.
So So there are, in some cases you have shown there's nystagmus, right?
Yes, yes, yes.
How and when do you advise a neuroimaging? The kind of nystagmus, how frequently do you advise?
In case of pure congenital nystagmus without any other systemic on examination, if there is no neurological association, we could see. In that cases, we won't go for if we suspect any neurological abnormality associated with nystagmus, we go for imaging. Otherwise, pure congenital nystagmus, we usually do not go for imaging, madam.
Have you tried prisms? Like nystagmus, sometimes, of course, there are surgeries for it.
This amplitude of the large amplitude nystagmus was there, and the patient was having significant chin posturing, and the deviation also was very large. So in that case, it's not good to try prisms, madam.
In the lesser frequency and small amplitude nystagmus, you can try the prisms. Okay, thank you. Thank you for the presentation.
Next, Dr. Soumya.
Unique subset of cataracts that can pose a challenge even to experienced surgeons. There is an inherently high risk due to the extreme thinness of the capsule with its tight adherence to the polar lens opacity, leading to posterior capsule rupture and even nucleus drop. The reported incidence of PCR during surgery varies, with older studies reporting an incidence of 36% to recent studies saying 7%. Several modifications have been suggested to enhance safety during surgery. Most of these are variations in hydro procedures during phacoemulsification. Hydrodissection should be avoided. Hydrodelineation can be done to create a mechanical cushion of epinucleus. Inside-out delineation and even pars plana lensectomy have been described. But in India, with its huge cataract burden, SICS plays a significant role, mainly due to low cost, easier access, wider applicability in high volume setups. Most residents are taught only SICS during their course. As budding ophthalmologists, it is ideal to be prepared to deal with posterior polar cataracts using SICS. Careful preoperative slit lamp examination should be done to rule out a pre-existing posterior capsule defect. After securing the superior rectus, initially, a side port entry is made to perform the rhexis. We prefer to do rhexis initially in an intact globe before creating sclerocorneal tunnel in case of compromised entry. While injecting viscoelastic substance, we need to be careful to inject only the optimal amount to fill the anterior chamber. Overfilling may increase the pressure on the capsule. Rhexis should be of adequate size so as to prolapse the nucleus into the anterior chamber. It should not be too large so that if the posterior capsule gets compromised, enough rim is present to implant the lens in the sulcus. Next, peritomy is done, followed by creation of the sclerocorneal tunnel. The size of the tunnel depends on the size of the nucleus and the grade of associated nuclear sclerosis. Hydrodissection should be avoided. Instead, Simcoe cannula can be used to gently hydrate and remove the loose cortex. This should be avoided in cases of pseudoexfoliation and cataracts with weak bag. Simcoe cannula is advanced beneath the capsular rim so that the cortex is loosened from the capsule without pressure on the capsule. This gives an effect similar to gentle multiple quadrant hydrodissection. The nucleus is then gently tilted and prolapsed into the anterior chamber while injecting viscoelastic. Visco is injected during each turn of the nucleus and thus brought into the anterior chamber. Alternatively, gentle hydrodelineation can be done. Fluid is injected in multiple sites in a controlled manner. The endonucleus is thus detached creating an epinuclear cushion. Again, Simcoe cannula can be used to prolapse the nucleus into the anterior chamber. Now, the nucleus is delivered using vectis, taking utmost care not to injure the capsule or the iris. This is the step most associated with posterior capsule rupture while doing SICS. The remaining epinuclear bits can be cleared using visco expression itself. The next step is cortex wash. The cortex is held at the tip and brought from the periphery to the center in a pattern similar to the reverse blooming of a flower. Sometimes a pseudo hole may be seen at the center, which may be mistaken for a PC rent. If a central plug remains, it will be prudent not to touch it and cause a PC rent at this stage. Instead, a YAG capsulotomy can be planned postoperatively. The IOL is inserted after careful inflation of the bag. Even minimal trauma by the IOL edge can cause a tear in the thin posterior capsule. Avoid excessive manipulation of the IOL in the bag. After washing out excess visco, wound is hydrated, main wound is sutured if required. Posterior polar cataract is a true challenge for cataract surgeons, but SICS is also a safe option to be kept in mind for those surgeons who are not yet well versed in phacoemulsification. We need not get intimidated, but be well prepared. Practical knowledge of SICS is also required if needed to convert from phaco in difficult situations. Patients and caregivers need to be well counseled regarding increased surgical risk, prolonged surgical time, and possibility of capsulotomy later. Different techniques have been described to minimize the risk, but it cannot be completely eliminated. Gentle maneuvering, maintaining the anterior chamber depth, and avoidance of hydrodissection are the mainstay. We can get equally good post-operative results doing safe SICS. Thank you.
So you are advising SICS or phaco for posterior polar cataract?
Actually, I advise phaco, madam, for the better results. But where the places we don't have phaco machines or anything like that, we have to teach them how to do SICS and in a PPC. We can't refer each time. So they need a technique. So I prefer SICS in PPC.
Then what is the advantage of using Simcoe itself for collapsing out other than a Sinskey hook?
Simcoe, no, I usually dial with a visco cannula itself, madam. In that video you can see, each time when you rotate, you can push some visco beside that nucleus and the lens capsule. So that each time when you rotate, the AC will be maintained. When you use a Sinskey hook, it will go through the main port and each time AC won't be maintained. But when you use a visco cannula to rotate the nucleus, you can push the visco each time when you go inside and push and then rotate, push and then rotate. And if there is some PPC, the detachment also will occur. That is, visco dissection will also occur along with that step. So in a single step, you can do all these things. Multiple instruments may also not be needed. That's why.
Will you do anterior vitrectomy when there is dehiscence?
Yes, madam.
So then you'll have to take phaco. No?
Yes, madam. Manual, if it's not available in our centers, we were not allowed to do that. Anterior vitrectomy with any machines. During our PG time, I used to do manual vitrectomy, then place the IOL.
In whatever, what I understand is that in whatever situations you have encountered, you are trying to do the best. That I appreciate it. The other thing that you can, what ma'am asked about why not use dialer is, most of these cataracts with posterior polar are very soft. So you can't in a sweep lift the
Yes, sir.
cataract. So your technique really holds good for
Yes,
that. And nevertheless, one comment that I want to give is, don't think after you have placed the intraocular lens,
Yes, ma'am.
your surgery is done.
Yes, sir.
Both in phaco or SICS, because the capsule is very thin and there is a tendency for it to give way. So the last step is when you're forming the anterior chamber, I would suggest that you form it so gently that you just hydrate the sections. And if you have made a side port in SICS, you form the chamber through the side port, okay? Because you can have a PCR
Even after putting the IOL, ma'am.
when you're forming the chamber.
Yes,
So that makes your life very miserable, okay?
Thank you.
Thank you.
Thank you.
This session is Krishna Prasad sir, just come. KP sir.
Next session, 5 minutes break. Continue.
Have 5 minutes.
But we are running short of time, right?
Okay.